Welcome to our webinar titled, I'm So Tired, Dealing with Fatigue and Other Symptoms with Bone Marrow Failure Disease. Thank you for joining us. My name is Lee Clark, patient educator, and I will be moderating the presentation today. As we get started, I'd like to recognize the generous support of our corporate sponsors and the generous support of our patients, families, and caregivers for supporting the webinar today. Due to the high volume of teleconferences on the internet, it is possible you may lose your connection during the program. If you are unable to view the webinar online, you can call in to hear the audio portion of the program using the call-in number in your reminder email. Today's program will be archived to our website within 2 to 3 business days. You will be notified by email when it is live and ready for viewing. Immediately following the presentation, there will be a question and answer session. Please feel free to submit your questions at any time during the presentation. To submit a question or comment, open the Q&A window in the lower part of your screen. Type in your question or comment in the small text box window. And when you have finished typing, just hit enter. We will do our best to get to all questions today. When asking questions, I do ask that you do 2 things to help me manage the incoming questions. First, submit your entire question all at the same time. Second, please do not share private health information in your question. Our speaker cannot answer any specific questions related to your personal health care. Today's specialist is Dr. Carmen Escalante. She is a professor and chair of the Department of General Internal Medicine with tenure at the University of Texas MD Anderson Cancer Center. Dr. Escalante established one of the first cancer-related fatigue clinics in the nation, and it has served as a model for other institutions throughout the U.S. and the world. With that said, it is my pleasure to welcome Dr. Escalante.
Thank you and welcome everyone. We'll get started. Next slide. So I want to acknowledge at the beginning that there is very limited data on fatigue and associated symptoms in most bone marrow failure diseases. So the majority of the data I'm presenting today is based on the knowledge we have associated with cancer-related fatigue. And I have seen both cancer-related fatigue patients as well as fatigue related to some of the bone marrow failure diseases. And so I have used that knowledge from my cancer-related fatigue experience to try to help our bone marrow failure disease fatigue-related patients. So just keep that in mind. Next slide. So the objectives today is first to define exactly what cancer-related fatigue is, the clinical importance of cancer-related fatigue, how we manage and treat this fatigue, and then I will share with you the fatigue and symptom burden in MDS, AA, and PNH based on study findings we did through this organization and the patients that participated in this study. Next slide. So much of what I'm going to share with you is based on the National Comprehensive Cancer Network guidelines that I am a member of and have participated in for years. There is also ASCO guidelines, the American Society of Clinical Oncology, that are very similar. These are all online if you want to Google, and you can review those guidelines. Cancer-related fatigue is a very distressing, persistent, subjective sense of not only physical, but emotional as well as cognitive tiredness or exhaustion. The major differential between cancer-related fatigue and other fatigue is that it doesn't get better when you rest. So it's not proportional to activity and it interferes with your functioning. Most of us, when we have fatigue, we rest, we take a nap, and we feel better. This doesn't happen most of the time with cancer-related fatigue. Next slide. It is the most common symptom in cancer patients. It surpasses pain. Its prevalence varies between 60 to 90%, and that variation is wide because it depends on the study that these numbers came from. In patients that have advanced or metastatic disease, meaning it's very diffuse, it exceeds 75%. We also know that it can be associated with psychological disturbance, with symptom distress, and functional status. Next. So many times, cancer-related fatigue is often unreported. And many of the reasonings have been shown that many times patients don't want to report it because they're afraid. They're afraid that if they say they have fatigue, perhaps they're not going to get their maximum treatment. And that's very important, especially in cancer patients, because they equivalent to them is that cancer, the more cancer treatment I can get, the optimum cancer treatment, the better my disease outcome. That may or may not be true. Also, many patients believe it's an expected symptom associated with their disease and it's untreatable and they should just deal with it. Others may think or classify themselves if they complain that their physicians and other providers are going to put them in a slot as a complainer, and they look at that as a very negative association. And others may believe it's a sign of recurrent disease or advancing disease, and denial is a big deal, and many patients don't want to know that. So they don't report it to their provider. Next. And healthcare providers, it's not only on the patient side, healthcare providers are often hesitant to bring it up. And many times because they don't have the knowledge in this area and there are limited treatment options. We'll talk more about the treatment options. And many of the clinics are busy and it's very time constraining, and they feel, well, if I don't have a lot of options to offer patients, why should I bring it up, especially if I'm really busy? It takes time to talk about fatigue. Next. Now, if we want to think about the pathophysiology, and again, this is focused on cancer-related fatigue and may or may not translate into bone marrow failure diseases fatigue. But there are lots of very interesting hypotheses or thoughts about what may be causing this in the body. There may be pro-inflammatory cytokines. These are substances in the body that may lead, that are associated with inflammation and may cause this prolonged fatigue. There may be in the brain, there's a hypothalamic pituitary adrenal axis, and this may be dysregulated. There may be circadian rhythm desynchronization, and this is associated with sleep and wake-sleep cycles. There may be skeletal muscle wasting causing this, or genetic dysregulation. These are all very thought-provoking, but there's limited evidence for any. The bottom line is we really don't know exactly what causes cancer-related fatigue as far as the mechanism. And it may take more time to figure this out. There are a lot of basic scientists trying to better delineate what's happening in the body, because if we can figure out the physiology or why this occurs, then we may be able to better target treatments if we know the mechanism of action, or we may be able to better predict who has prolonged fatigue in these cancer patients. Next. So some of the causes of cancer-related fatigue. Fatigue is a very non-specific symptom. There is no lab test I can order. There are no uh, other imaging studies I can order to determine fatigue levels. Like, for example, anemia, I can order a hemoglobin level. And when we evaluate for fatigue, we have to consider everything. So it takes time. And those everythings include what kind of cancer treatment did the patient get? What kind of treatment effects came from these cancer treatments, including anemia, hypothyroidism, can be some of the treatment effects. What kind of other symptoms coexist, such as pain, sleep disruption, depression, anxiety, because we know that the higher the symptom burden, meaning the more other symptoms that coexist or often are common in patients with fatigue, can increase the fatigue level. Nutritional aspects extending from either malnutrition, nausea causing decreased nutritional intake, dehydration, all those things need to be considered. Other comorbidities, including things like uncontrolled diabetes or coronary artery disease, pulmonary disease, all these can contribute to fatigue. Medication side effects. Many of our patients, and my patients, are on numerous medications that can have side effects. And some of these side effects can contribute to fatigue. Next. So we need to do early screening and symptom management. We should screen both during the course of treatment and post-treatment. The level of cancer-related fatigue can easily be spotlighted on a numerical scale from 0 to 10, where 0 is no fatigue to 10 is the worst fatigue I've ever had, to kind of get an idea of how bad the fatigue is. And instituting a brief scale in a busy clinic may be the best way to go. No one has time to do a very involved scale just to determine, is it mild, is it moderate, is it severe? So we know what screening pot to put you in. So next slide. So the approach to patients with fatigue is generally, we try to categorize it between mild, moderate, or severe, so that we can separate those that may need more evaluation. So those with no fatigue to mild fatigue, which on a 0 to 10 scale, we classify 0 to 3. If you have no to mild fatigue, we still would educate you about fatigue. So if it does occur, you know what to expect. We would do some general strategies to manage fatigue. If it is more moderate, which would be on a scale of 0 to 10, 4 to 6, or severe, where we would categorize you at 7 to 10, we would not only do the education and the general strategies, but we would add in a primary evaluation. Next. So when I talk about general strategies, what do I mean? So some of the general strategies that, again, we would incorporate from no fatigue all the way to 10. Self-monitoring fatigue level. We do know that things change for our patients. Patients that get treatment may fluctuate depending on the type of treatment. So monitoring the fatigue level, because it may be no fatigue at one part of the cycle and severe fatigue at a different part, especially shortly after chemotherapy or other treatments. Energy conservation. And what do I mean by energy conservation? Setting priorities. And I go through this with my patients all the time. Uh, Prioritize what's important to you, what you really need to do. And you want to do these when you have the most energy. Pacing yourself. There are going to be some days better than others. Sometimes when you feel you can do more, and sometimes when you can't, and you need to listen to your body. Delegating. Not everything has to be done by you. And there are likely people around you, whether there's family members, people in the office, friends that want to do things for you. So delegating what you need to do, what others can do, whether you need to hire that housekeeper to help you with some of the housework. And again, scheduling activities, especially activities that are harder to do at times when you have peak energy. So knowing when, if you can determine during the day what your fatigue cycle is, what part of the day do you have most energy and what part of the day you don't. Many of my patients can tell me very quickly that, oh, the morning's better or the afternoon's better. And sometimes doing a fatigue diary can help you to determine what time of day is best if you haven't really paid attention. Using labor-saving devices. For example, a shower chair in the shower, a terry robe to wipe yourself instead of bending over with a towel after showering or bathing, a stool in the kitchen to chop your vegetables or seasoning, or when you're cooking or washing the dishes. Postponing non-essential activities. So if you're having a bad day or you're having a lot of fatigue, if these things are not essential, put them off for another day and schedule your week ahead of time so you don't put all your really strenuous activities on the same day. Limiting your naps to 20 to 30 minutes so it doesn't interfere with night's sleep. Next. Structuring your daily routines. So, you know, if you want to exercise and the morning's better, you have more energy, then taking that morning walk then, or going to the store then to get some groceries. Using distractions. Many times, if we are distracted by other things, we don't think about, I feel so tired right now. And distractions may include listening to music, reading, games, puzzles, other things. Next. Part of the primary evaluation, which we would do for patients that have persistent, moderate to severe fatigue, includes getting a focused history. So when my patients come to see me for an evaluation for fatigue, some of the things I want to know is what's your disease, what's the disease status, and what treatments have been received. We do know that patients that get chemotherapy or immunotherapy may have more fatigue than patients that get surgery alone or radiation alone. And those patients that get very intensive, what we call multimodality treatment, meaning combinations of chemotherapy, radiation therapy, especially stem cell transplant, tend to have more fatigue than those that get more limited treatment. I want to know about the status of the malignancy. Is this a reoccurrence? Is this progressing? What are the current medications or recent medication changes? I know that certain medications, beta blockers for heart disease or pain medication, sedating medication may contribute to fatigue sometimes or drowsiness. And I want to look at the prescription medications as well as the over-the-counter medications and supplements. We also know that there can be drug interactions and over-the-counter medications, especially herbals, there can be interactions between medications. So I ask my patients about these, and sometimes Patients may not consider some of these over-the-counter meds and supplements as part of their list of medications. Next. I often, I always, not often, but always go into a fatigue history. There are certain things I want to know about the fatigue. When did it start? Is there a pattern, like we talked about? Is it worse at a particular time of day, or is there no pattern? How long has it been going on? Patients that tell me this has been all my life, even before I had cancer, this is not typical of cancer-related fatigue. And there is a difference. I don't treat chronic fatigue syndrome. I treat cancer-related fatigue. Has there been a change over time? That may help me and can be revealing. Are there other associated factors or alleviating factors? Patients sometimes tell me it's worse with activity. Or if I exercise, I feel better for a short time and then I feel worse. Or if I rest or take a nap, I feel better after. Does it interfere with function? Meaning, can you not do certain things because of the fatigue? Or are you still working outside the home? Or are you able to go out with your family to dinner? Or are there certain, can you go to the grocery store? Those kind of things tell me a lot. Next. The other factors that often can contribute, and we mentioned before, are other symptoms. And in our clinic, we do a symptom survey of tools. So things like pain. Is pain associated? Is there emotional distress, meaning anxiety or stress or depression? And we do these survey tools, and I get a number, or but I always tell my patients, I don't treat numbers, I treat patients. So the survey tools have to clinically correlate with what the patient is telling me. And most of the time they do very nicely. Sometimes they're disparate. And if so, I go with what my clinical instinct and what the patient is telling me, not necessarily what the survey tool is telling me. Is there anemia? We know that patients with anemia have fatigue, especially in our bone marrow failure diseases. Or are there sleep disturbances? Obstructive sleep apnea. I've diagnosed several patients with sleep apnea, which when we fix it can help. Is there insomnia? We go back to basic sleep hygiene tools, restless leg syndrome. So getting a good history about sleep is really important. Many times it's multiple factors, not just one thing. And often, when there are multiple factors, I can't tell you what percent is coming from pain, what percent is coming from anemia, what percent is coming from the treatment of the fatigue. What we do is try to address the low-hanging fruit, so to speak, first. What things can I fix readily and see what impact it has on the fatigue. Next. Other factors also include nutrition. Are you eating a healthy diet? Are you eating appropriately? Especially my patients that have had gastric or stomach cancer or have a malabsorption, they may need a nutritional assessment if they haven't had one by one of our nutritionists. Is the weight underweight or overweight? Because both extremes you can still have nutritional deficiencies, and that may impact your functional status and ability to do things. The appropriate intake of, and I always get questions about vitamins. I tell patients, if you're eating a healthy diet, an appropriate diet, most patients don't need nutritional extra vitamins. Now, patients that may have malabsorption and not getting appropriate vitamins may need vitamins. If you are not eating appropriately, a multivitamin a day may be helpful, but excess vitamins do not improve fatigue. And are there fluid and electrolyte imbalances? If you're having a lot of nausea or diarrhea, this may be the case. So we need to look to not forget about this when evaluating patients. Looking at functional status, what kind of physical activity are you doing? Can you do your activities of daily living, meaning can you dress yourself? Can you fix your meals? Can you feed yourself? Are important to understand. Are you using extra devices like walkers or canes? And what's the level of deconditioning? Because we're going to talk about interventions, but exercise is one of the mainstays. And for me to understand what kind of, where we're starting from, what is your baseline physical activity, and how long has that been the case is very helpful. And again, looking at the medication side effect profile. Next. I want to understand your comorbidities. Many of my patients have several comorbidities, and are they optimized because they can contribute to fatigue. I want to know about alcohol and substance abuse, whether you have cardiac or endocrine or hepatic dysfunction, or is there an ongoing infection? Is there neurologic or pulmonary or kidney dysfunction? Because all of those things, if they're not optimized, can certainly contribute to fatigue. Next. So before we go into interventions, understanding all of those factors are very important. And as I said before, many times it's not just one thing. It's multiple things that are contributing to fatigue. And again, looking at all of them, figuring out which things I can make the most impact on. So let's move on to the intervention. So now we understand we have fatigue. How am I going to improve upon that? There are two main classes of interventions that we utilize. And those are non-pharmacologic and pharmacologic. When I mean pharmacologic, I mean drugs. So let's start with the non-pharmacologic. Next. So in the big groupings of non-pharmacologic interventions, there's physical activity or exercise. And what I mean by category 1, when we go to these guidelines I mentioned earlier, we rate the evidence, the data that's there. And clinical trials, randomized clinical trials is that the supreme top of the data. And if there's enough evidence to show that this was done, objective evidence, it gets a category 1. That's the highest level of evidence. So we can see that physical activity has a very high level of evidence. And all of my patients with fatigue, I try to start with some physical activity, depending on where we're starting from, baseline. There's psychosocial interventions, and we'll talk more about those because some of the psychosocial interventions have a category 1. Sleep therapy and nutrition are the biggest buckets. Next. So let's talk about physical activity with the category 1 evidence. First of all, when we start with the regimen, we want to individualize it. As you're well aware, some patients have a much higher level of physical activity than others. Some of my patients have never exercised their entire life, before, not even before cancer. And they may have other issues that prohibit certain types of exercise. When we consider exercise, we consider both endurance and resistance. Endurance is more cardiovascular. There are data to show perhaps the cardiovascular might improve fatigue a little better than resistance. But from my experience, you need a combination of both to have a good, healthy exercise regimen. The other things I want to know when I'm considering the physical activity is what type of cancer, or you could say bone marrow failure disease, we're dealing with. And is the therapy ongoing? And what type of therapy is ongoing? Because we know that the fatigue's going to fluctuate. And those patients that are receiving active therapy, there are certain times during the therapy, and either administration or shortly after, where there is less ability to endure exercise, and it may have to be amended. And as I said, the things for physical fitness level, especially in cancer patients, and may extend to bone marrow failure diseases, that we need to consider when we're coming up with an exercise program is, do they have malignancy in their bones? Because this can cause an easier risk of fracturing or breaking a bone if they do certain type of exercises or if they fall. Is the platelet count low? Do they have anemia? Because we know that the lower level of anemia can precipitate, especially in a patient with heart disease, chest pain or more shortness of breath. Is there fever or active infection? There may be limits not only from the cancer that has spread to other organs, but to other comorbidities, as we talked about. Those patients with severe heart disease or lung disease may not be able to do certain types of exercises or as much exercise. And again, safety issues, which patients may be more at risk of falling. If you have neuropathy, meaning numbness in your hands or your feet, especially the feet, because some of the side effects of cancer treatment can be neuropathy. Some drugs cause neuropathy. You may be at a higher risk of falls. Yoga has category 1 level in cancer-related fatigue. And so that might be an option as well. Next. Massage therapy, and we look at what we call physically based therapies. In cancer-related fatigue, massage therapy has been shown, although there is some limitation in data, a category 1, that it can be helpful. You have to remember, though, if your platelet count is low, you cannot have deep massage. And depending on where the tumor may be, there may be certain areas, especially in the neck or the spine, knowing if there's disease there, that you need to work closely with the massage therapist. Next. Psychosocial interventions include cognitive behavioral therapy or behavioral therapy. This also has a category 1 level of data. And what we call psychoeducational or educational therapies, also some of these have a category 1. They're included in psychosocial interventions include supportive therapies like expressive therapies, meaning support groups, counseling, journal writing. There have been studies in these. The data is not to a category 1. It doesn't mean that it may not be helpful for some patients. Next. So if we want to talk about cognitive behavioral therapy, the most work has been done in the sleep realm. And for many of my patients, sleep is an issue, especially insomnia. We see both extremes, from those patients that can't sleep to those patients that feel sleepy all the time. And it can be an effective sleep intervention. There's some sleep hygiene is really important, especially in insomnia. So what we talk about is stimulus control, and some aspects include going consistent bedtimes and getting up times, avoiding caffeine and stimulating evening activity. Exercise is a stimulating activity. You do not want to exercise in the short hours before bedtime. If you're going to exercise in the evening, you want to do it several hours before bedtime. Restricting sleep, meaning avoiding long or late naps. I tell patients, I'm okay with you napping as long as it's not interfering with your night's sleep. When you have your time to go to bed gets later and later, and you can't sleep as well, and you notice you're taking 3 and 4 hour naps during the day, it's not going to work. And the biggest problem is when patients flip their daytime and night times, so that you're sleeping more in the day and you are awake more at night. Doesn't work very well, and it's very difficult to go back. And we do a lot of education and counseling on sleep hygiene. Pharmacologic therapy, many patients say, well, can I have something for sleep? A hypnotic is what we call our sleeping pills. These are meant to be short-term only. They do not work well. They can be addictive. I don't like using them unless they're very short-term. They can often interact with other sedative medicines like medication for pain, narcotics, medication for neuropathy. Lyrica and Neurontin often can cause sedation, and this can make it worse. Anxiety medication. So you have to be really careful, especially if you have sleep apnea. Not a good idea to take a hypnotic. Next. There has been some work in what we call bright white light therapy. Some patients with cancer-related fatigue, there have been studies where you use 10,000 lux, that's the wattage, has been the most frequent, self-administered in the early morning for 30 to 90 minutes. The timing needs to be adjusted for those that are sleeping in the day, but you know, especially trying to get patients out into the light can be helpful, even if you don't have this bright, very bright white light. But there has been work done in bright white light therapy. Next. Nutrition. Nutrition is very important. Educating about nutrition, healthy nutrition, because especially for our cancer survivors that have finished therapy, eating healthy, a healthy lifestyle means eating healthy, getting enough sleep, exercising, all important aspects to healthy living. And as I said before and gave you examples, for some patients, it may be appropriate to refer to a nutritionist. And we know that being overweight can be just as bad as being underweight. And so getting to the right baseline weight can be helpful and help to increase that activity. Many of my patients may have arthritis and knee problems because they're very overweight, and it's very difficult for them to walk and have pain in their hips and low back and joints. Sometimes water therapy, water exercises may be helpful in those particular patients, but also weight loss. And it's hard. It's not an easy feat. Pharmacologics may be appropriate. Examples for nausea. I do not use diet pills. I do not believe those are an easy fix. I have referred patients that are extremely overweight and fit certain criteria for consideration for bariatric surgery. But you know, there's no easy way to lose weight. But healthy eating is going to be really important, especially during this pandemic. Next. So let's go to the pharmacologic bucket. Some of the things that have been tried and used fall into 3 buckets. And again, not everything that has been tried works. So stimulants or drugs that have been used for various other indications. There are no stimulants, there are no pharmacologics at all that are FDA approved for cancer-related fatigue. So if we use them off-label. And then antidepressants, and I will talk to you about those, and steroids. Next. So, stimulants. The stimulants have been studied in several different trials. It's a mixed bag as far as the outcomes. There have been, most of the work has been done with methylphenidate, both short and long-acting methylphenidate. Methylphenidate, the trade name is Ritalin. It's FDA approved for attention deficit disorders. It's been used for years in children and adults. It was first used in the oncologic population for sedation. For many of our patients that had severe pain, we used narcotics. Narcotics cause sleepiness, and we used methylphenidate to help with the drowsiness. And when cancer-related fatigue became an issue, we noticed for some patients it helped. And that's still the thing. It works for some patients. There's a big placebo effect in the stimulants. So whenever we do a clinical trial, we have to have a placebo arm. We usually use low dose methylphenidate. In most of my patients, it's pretty well tolerated. It doesn't work as well as the non-pharmacologic methods that we talked about. And I consider it often, it depends, after I try to treat other causes. In my experience, it works better in patients that have some component of cognitive fatigue as well as physical fatigue. We don't understand how it works. My hypothesis, from my experience, I think it may help in focusing our patients more, and that's why it was approved, so that you are more organized and you feel like you get more things done. And you feel then you have more energy, but we really don't understand the mechanism. Other stimulants are modafinil and armodafinil. There's less literature. These two stimulants have been used for patients that have pulmonary dysfunctions like sleep apnea or shift work disorders. They are more expensive. It's hit or miss as to whether the prescription drug coverage will cover it. Most of these, especially the modafinil and armodafinil, in my experience, is only approved if you also have sleep dysfunction and have a sleep study, because they are more expensive. Many of my patients, if I'm going to use a stimulant, will use methylphenidate because it is generic and it's fairly cheap. And so if the prescription coverage doesn't cover it, my patients can often afford to buy it out of pocket. Next. The antidepressants do not work for fatigue per se. If there is depression with the fatigue, then it works to help with the depression. But studies have been done looking at antidepressants just for fatigue, and there have been no positive studies that show that an antidepressant will improve fatigue only. And the groups of antidepressants that have been utilized for these are this, what we call the SSRI, selective serotonin reuptake inhibitors, the secondary amine tricyclics, and bupropion, known as trade as well Buterin. Again, I do not prescribe these for fatigue. If a patient has depression and we want to use an antidepressant, then I'll prescribe an antidepressant for the depression that may coexist with the fatigue. Next, steroids. Steroids are drugs like prednisone, dexamethasone, and they have a lot of side effects. They are good drugs. We use them for numerous issues in patients, not only cancer patients. But because of the side effects, we only use these for fatigue in patients at the end of life with advanced cancer. They generally relieve fatigue very short term, and they may improve the quality of life. But because of so many side effects, you cannot use this drug long term. For patients with diabetes or tendencies, pre-diabetics, it's going to increase the glucose. It can cause weight gain, sleep issues, irritability, lots of side effects. So unless a patient is near end of life, and I think that this is an appropriate treatment, then I'll use it then. But otherwise, I don't use it. And as you can see, there are very limited pharmacologics for treating cancer-related fatigue. As I tell my patients, there is no magic pill. There's nothing that works really well just for cancer-related fatigue, other than the methylphenidate that I use in conjunction with these other non-pharmacologic therapies, and it may work, it may not. Non-pharmacologic therapies have the best data, and those are the ones with the category 1s. Next. So I want to briefly talk to you about a study we did. I've done previous talks for this foundation, and at one point I said, wait a minute, we don't have any data on bone marrow failure diseases. Let's work together and see if we can get some data in these patients. So we did a prospective study to look at fatigue and other symptoms, pain, depression, anxiety, stress, in patients with MDS, aplastic anemia, and PNH. And in the database, we used the database from the AA and MDS International Foundation, and we administered surveys from their website from October of 2014 through April of 2015, and looked at a cross-sectional study. And if you want to look at the study more, I put the reference down at the bottom. Next. So we had 303 patients sign up. It was a voluntary thing. Almost half had MDS, almost a third or 30% had AA, and about a quarter had PNH. Of those, about 10% had more than one of these diagnoses. The mean age was about 57, about 2/3 were women, and almost all were white. Next. So we wanted to look at the fatigue scores, and we used this survey tool called the FACT anemia. The higher the score, the less the fatigue, and the score range was 1 to 25. If we looked at the whole cohort, it was the score was a 25, and as you can see, those with AA had a 28, and MDS and PNH were 24. So they were all fairly severe levels of fatigue. Next. We wanted to look at quality of life, so we looked at the subscales of the same survey tool. Again, it ranged from 10 to 104. The higher was the better quality of life. So the whole cohort was about 68, with AA at 67, MDS 69, and PNH of 67. Next. And then we looked at the other symptom scores. So stress was normal, pain was mild, and again, this was the whole cohort. Depression was mild, and anxiety was moderate. And we know that if some of these other symptoms are high, it can often influence fatigue. Next. And we asked patients about their management strategies and which they perceived as helpful for fatigue. And the things that they felt helped the best was preserving energy, was physical activity, and naps. So this gave us some insight, at least to start with, because we had very little data. MDS, of the patients with MDS, there are a few studies out there looking at MDS, but AA and PNH, there was virtually no data. So it gave us some idea of, what is the level of fatigue, because as you heard, I'm extrapolating a lot of what I'm talking about from the cancer-related fatigue data. And we see a lot of crossover with that data in these populations. Next. So in summary, we know that fatigue is a significant issue, not only for our cancer patients and survivors, but with patients with bone marrow failure diseases. And we know from the cancer literature, those patients with more liquid tumors and more extensive diseases like the stem cell transplants tend to have more fatigue. We know that evaluating and treating this level of fatigue requires a multidisciplinary approach, meaning we need to look at multiple areas. I may need to work with other physicians to try to improve the fatigue. Where are the opportunities? Because we always have to look at where do we go next. We know there's a lack of data regarding fatigue and other symptoms for most bone marrow failure diseases. I got a little data that was cross-sectional, that wasn't clinical trial, and these are very rare diseases. So to try to do a clinical trial is very difficult. There's a lack of pharmacologic agents, not only for bone marrow failure diseases, but for cancer-related fatigue, which has a lot more patients. There are lack of well-designed clinical trials looking at pharmacologic agents, and there's a very sparse area of pharmacologic agents available to treat cancer-related fatigue or any type of fatigue. And there's lack of well-defined pathophysiology for cancer-related fatigue so that we can target interventions. As I told you, all of the mechanisms or hypotheses, none have been proven at this point. So there's lots of areas that really need to continue to be studied. And as we do better with not only cancer-related fatigue treatments, but bone marrow failure treatments, we're seeing longer survival with higher levels of fatigue because of the intensity of the treatments and the treatment types. So I wanted to leave time for your questions, and that will conclude my presentation.
Thank you very much, Dr. Escalante. We do have a few questions. Our first question comes from an MDS patient that was diagnosed 11 years ago. Recently, they've been suffering more severe fatigue. Their CBC and CMPL blood tests show no changes. Their pulmonologist and cardiologist can't find any more problems to cause the acute fatigue. What could quickly make the fatigue so more extreme?
Well, the things I would think about is if, the treatment was distant and usually treatment effects plateau, at least for cancer-related fatigue, in between 6 months to a year after treatment. And so that effect from the treatment itself, usually after about a year, most patients, the fatigue associated with that treatment does not tend to get a whole lot better after that time point. So I think about some of the other things we talked about, other symptoms, other comorbidities, changes in function, and some of those aspects, if the counts and the treatment and those kind of things and the disease status hasn't changed. Those would be some of the areas that I'd explore.
Thank you. Could acute fatigue be due to a higher increase in cancerous bone marrow stem cells overpowering healthy stem cells? If so, what can be done to eliminate the cancerous cells to make room for healthy ones? Before this problem, this patient had done a couple rounds, 6-month regimens of Dacogen.
So we know that the extent of the disease and the type of treatment can affect, so that patients that had, for example, stable disease, and now their disease is progressing, or their disease had gone away and now it's recurred, certainly can increase fatigue. And, every disease is different. Even every cancer can be different. And so having a discussion, if the disease is progressing or the disease is recurring, then talking with your provider, oncologist, hematologist, whoever you're seeing, what's the next step? What are the pros and cons of each treatment and the side effects? And, you know, many times if the disease, the fatigue, the majority of the fatigue is being caused by disease progression or worsening or recurrence, and it's then treated and it decreases and responds to the treatment, the fatigue may get better. I definitely, and we know that if the malignancy or the marrow disease progresses, the fatigue certainly can get worse.
Thank you. Will taking melatonin help get quality sleep?
Oh, thank you for bringing that up. I do suggest that for some of my patients, that if they want to take something, rather than a prescribed hypnotic, to try melatonin. Yes, it can. Not all of my patients find it's helpful, but in conjunction with sleep hygiene. I think not just taking the melatonin itself, but you know, doing the right things as far as sleep. You want a cool, dark room. You want to avoid all the caffeine and other things, exercise, stimulating things before bedtime. You want to go to bed at the same time, get up at the same time. If you wake up, there are two components of sleep, being able to fall asleep and stay asleep. And some patients can do one and not the other, and some can't do either. But if you wake up at night and after 15 or 20 minutes, you can't go back to sleep, I tell my patients, go in another room, get a book, a boring book. You don't want a suspense novel, or listen to relaxing music. No electronics. All the screens are stimulating. The phone, the iPad, the computer, you want to turn those off about 30 to 60 minutes, preferably 60 minutes before bedtime, so you can fall asleep. So, and read or listen to music or do something relaxing till you get sleepy, and then go back and lay down. And you repeat that cycle as many times as you need to. But the key is you still have to get up at the same time, and you still have to go to bed at the same time. But taking melatonin in conjunction with that can be helpful.
Thank you. You had mentioned chronic fatigue syndrome. What's the difference between chronic fatigue syndrome and the fatigue that is suffered by many of the bone marrow failure patients?
Chronic fatigue syndrome is a whole nother ball game. And my experience, I don't treat chronic fatigue syndrome. These are often years of fatigue, and it's not precipitated by the cancer or bone marrow failure. I've had a few patients that have had chronic fatigue and then they get cancer, and often the fatigue is exacerbated, but it's very different than cancer-related fatigue. And the guidelines I mentioned are specifically focused on cancer-related fatigue.
Thank you. And our last question comes from a patient who says, I find it difficult to explain to family and friends that when I'm tired, it's not the same tired they experience. What's the best way for me to explain to them my tiredness so they understand?
So I think the way you should explain is, if you go out and take a hard run, or you really have a hard day and you're really tired, you're going to come home and you're going to rest or go to sleep, and then you're going to get up and you're going to feel all fired up and ready for the next day. With cancer-related fatigue, I don't have to do a whole lot of running or walking, and I'm tired. And I can lay down and take a nap or just rest, and I don't feel any better. And that is the biggest difference between the fatigue your family experiences and the fatigue you experience.
Well, thank you so much, Dr. Escalante, for sharing your time and your expertise with all of us. If you would like to watch this webinar again at a later time, it will be available on our website within 2 to 3 business days. If we were not able to get to your question today, please send it to us at any time in 3 ways. Send an email to help@aamds.org, call our helpline at 800-747-2820, extension 2, or submit your question on our Facebook page. On behalf of the Aplastic Anemia and MDS International Foundation, thank you for joining us today, making us your resource of choice for information on bone marrow failure diseases. The AAMDSIF Medical Advisory Board and team are here to support you and your family as we have done for the past 36 years. This concludes our program. Thank you, Dr. Escalante.
Thank you. My pleasure. Y'all have a great day and stay safe.
Take care, you too.
Bye-bye.